Hello everyone, thank you for joining us for our monthly webinar. We appreciate your patience. We were having a little bit of technical difficulty as we were logging in, but we see that a lot of you are online and ready for this webinar, and we're excited that you stayed with us and are able to join us today. My name is Leslie and I'm going to be your moderator. A few quick ground rules before we get started as usual. We're going to keep the phone lines on mute, but we encourage you to ask questions. If you have a question, please put it in the questions box. We'll answer all questions at the end of the webinar. And if we don't get to your question for some reason, we have your email and we will answer you in writing. We're also posting a video and a PDF of this presentation on mceda.org under the tab Resources a little bit later today or tomorrow. Actually, the presentation slide is available right now in that area if you need it. Our presenter today is Bruce Mackey. He's our in-house regulatory incentive program analyst. He will be walking us through what to expect for Stage 2 meaningful use, including a summary of the objectives and measures, recent changes, and particular items to note. For those of you who don't know MCEDA, we are the Michigan Center for Effective IT Adoption, a program that is led by the nonprofit Altarum Institute. We were chosen as Michigan's official regional extension center in 2009 by the Office of the National Coordinator to help accelerate the adoption, implementation, and effective use of EHRs and meaningful use. We are one of only 62 in the whole country, and we are primarily funded through the Centers for Medicare and Medicaid Services and the Michigan Department of Community Health. To date, we've helped over 6,000 providers with EHR adoption and implementation, and our program offers highly subsidized health IT assistance for qualified physicians under grant funding. Paired with our fee-for-service offerings, we cover meaningful use support, security risk assessments, targeted process optimization, and attestation and audit preparation assistance. With that, I'll turn it over to Bruce to get started.
Thank you, Leslie. And again, I apologize for the late start. You'd think with the masters of the health IT, but we were vexed by some IT issues over here, which can happen to anybody. We changed rooms from where we usually do these webinars, and the technology didn't play nicely in the sandbox. So I appreciate everyone hanging in there. I still see we have quite a few folks that stayed on, so I'm happy to see that. So as Leslie said, I will be kind of talking through meaningful use, focusing primarily on Stage 2. I just got to note that there is no sound coming through. I want to make sure that folks are able to hear me. If folks out there can hear me, can somebody, yeah, okay. So everyone else can hear me. Thank you. Lisa, you might need to try and dial in. Yeah, thank you, everybody. I got many messages that you can hear me. I'm glad to hear that. Thank you. Okay, so we're going to move on. Lisa, you might have to try and either use your phone or if it's not working through the speakers on your computer, just switch your interface over to the telephone number, and you can dial in that way as well. Okay. So real quick, I'm not going to spend a lot of time on what meaningful use really is, but these are kind of the standard slides I typically keep in here for anyone that's somewhat new to the program. Meaningful use is defined by CMS, is using certified EHR technology, or CERT, to improve quality, safety, efficiency, and reduce health disparities, engage patients and families, improve care coordination, population, and public health. That's a big, big part of it, especially as we move into Stage 2. And maintaining the privacy and security of patient health information, a very, very important part. We all see over and over again where that isn't happening, like the recent Anthem debacle. Ultimately, this hope that meaningful use compliance will result in better clinical outcomes, improved population health outcomes, increased transparency and efficiency, empowered individuals, and a more robust research data on health systems. In short, meaningful use is the use of EHRs in a way that positively affects patient care. Most or all of you have probably seen this slide before. It just kind of maps out the way that meaningful use program is. It's broken up into 3 different stages. Everyone is in each stage for a minimum of 2 years. Some of you on the phone were probably in Stage 1 for as long as 4 years before moving on to Stage 2. But with each advancing stage, the measures change, the bar is raised, and we kind of push those thresholds higher and higher. A lot of folks are into stage 2 for the first time this year, which is why you're clued into today's webinar. We should be seeing some information on stage 3 coming out really any time now. The kind of proposed stage 3 stuff should be coming out as soon as this month, as I've heard it, and with a final rule slated for later this year. Meaningful use timeline kind of maps out, again, kind of what I said about everyone being in each stage for a minimum of 2 years, with most folks venturing into stage 2 finally this year. So let's talk a little bit about kind of what happened if in last year there was this thing called the flexibility final rule that kind of changed the landscape in meaningful use, allowed folks who would have been on the hook for stage 2 to kind of flex back and do stage 1 again. There were a lot of issues with technology that prevented folks from being able to meet the stage 2 requirements due to not being able to properly or fully implement their 2014 certified software. So there was some flexibility that was worked into the program that allowed folks to still attest to meaningful use. Those that would have been in stage 2 could flex back to stage 1. Those that were in stage 1 but weren't upgraded to their 2014 technology were able to still attest on their old technology. And so a lot of folks were able to flex. But the question that we get a lot now is, okay, what does that mean for 2015? Where am I at in 2015 if I flexed last year? So both the Medicare and Medicaid program are very similar, but there is a big difference between them as well. So in the Medicare program, the stages and years progress whether or not the provider met meaningful use or whether or not the provider used a different cert option in 2014. So if you didn't do anything in 2014 and you're in the Medicare program, the program advanced without you. And so if you were on the hook for stage 2, year 1 last year and you didn't flex, you didn't do anything, you're actually in stage 2, year 2 this year. If you did flex, if you were supposed to be in stage 2, year 1, and you flexed back to stage and did stage 1 again, that took the place of your stage 2, year 1 attestation. So again, you're actually in stage 2, year 2 again. That follows suit. Part of that follows suit in the Medicaid program. So if you did attest last year using the flexible options, that took the place of whatever stage and year you would have attested to in 2014, and the program clock then advanced forward into the next stage and year. So again, in the Medicaid program, if you were on the hook for stage 2, year 1 last year, you chose to flex back down to stage 1. Again, you are, because you did attest in 2014, that took the place of that stage 2, year 1 attestation. You're now in stage 2, year 2. The main difference between the Medicare, and one of the main differences between Medicare and Medicaid is the ability to pause in the Medicaid program. So you didn't need to attest to meaningful use in 2014, and the program just kind of went on hold and waited for you to re-engage. So if you didn't do anything in 2014, if you would have been in stage 2, year 1, but chose not to attest to meaningful use in 2014, and you're in the Medicaid program, that means you are now in stage 2, year 1 this year. So again, the program advanced. If you did attest, you moved forward, but if you did not attest, the program kind of went into a holding pattern and waited for you to come back. Okay, I'm going to move on to the meat of the presentation and talk about stage 2. So what's the difference between, what does stage 2 mean to you? What are the big differences between stage 1 and stage 2? So in stage 2, there's new criteria. Some folks actually attested in 2014 to stage 2, but the vast majority of folks chose to flex or just pause in the program and not do stage 2. So if you've met the criteria in stage 1 for at least 2 years, you are advancing on to stage 2 this year. In stage 2 includes some new objectives to improve patient care through better clinical decision support, and really pushed a lot of the thresholds higher, which you'll see as I advance through these next slides and go through each of the measures. I'll point out those differences between stage 1 and stage 2. Overall structure between stage 1 and stage 2 at a glance. We see that in stage 1, EPs were on the hook for 13 core objectives, and then we're choosing 5 out of 9 menu objectives for a total of 18. In stage 2, you're on the hook for 17 core objectives, so that number has significantly increased. But on the menu side, you're only on the hook to choose 3 out of 6 menu objectives for a total of number of objectives at 20 in stage 2. Do I need to upgrade my EHR? Yes. If you are still on 2011 technology, you have not gone through your upgrade for your vendor up to the 2014 version, you are way behind and are honestly at this point today in jeopardy of not being able to attest to meaningful use at all in 2015. So if you have not gone through your upgrade, you need to get that done immediately. As the law stands right now, I'll touch on this in just a second, but as the law stands, you are in a 365-day reporting period right now today. That's likely going to change. I'll touch on that a little bit more in a second. But if it does not change and you are not on your 2014 technology, you cannot attest to meaningful use because you have to be on 2014 technology on day 1 of your reporting period. So as I just alluded to, there's change likely coming, but is not in place yet. So as it stands right now today, the law states that anyone who is beyond their first year of reporting in meaningful use is in a 365-day reporting period. That is, your reporting period started on January 1st of 2015 and goes through December 31st of 2015. That is likely to change. CMS came out with some information at the end of February that indicated they were considering changing this to a quarterly reporting period, which is kind of what happened last year as well. So everybody was on the hook for either a quarter reporting period or 90 days in 2014. We believe that is the direction it is likely going to head in 2015, but we will not see that happen, or we will not get official word of that. My guess is as late as Q3 of this year. So it's going to be a while before they officially make that change. So really, until they do, you need to be acting under the assumption that you are in a 365-day reporting period. I think this, if this program has taught us nothing else, it is that you can't count on things changing. The program is constantly being flexed and updated and changed. But right now, you should not count on things officially changing to a quarterly reporting period. You should be acting as though you are in a year-long reporting period until CMS makes that official change. But my feeling is though it actually will. We'll see. What are the stage 2 objectives? Kind of touched on this already. You've got the 17 core objectives, you've got the 3 menu measures, and you add the clinical quality measures into it, which I'll touch on once I get through all the different measures, the core and menu measures. But that formula gives you stage 2 meaningful use. Here's a look at, from a high level, what the core measures in stage 2 constitute. I'm going to be going through each one of these in a lot more detail and kind of pointing out the main difference between stage 1 and stage 2, kind of what changed on these measures. So as I said, over the next several slides, I'm going to go through each one of those measures and point out those main differences. This is a very quick, high-level view of each one of them. There is a lot of details behind meeting each one of these objectives that I do not have the time. It would literally take about 3 hours to go through a deep dive, and we are not going to do that to you. We're going to stay pretty high level. So if you are interested in some very heavy reading on each one of these measures, the URL at the bottom of this slide, if you go there, you can get to each one of the spec sheets on each one of these measures that will give you exactly what I'm going to cover and a wealth of other data behind each one of these measures. Okay, so the first measure in stage 2 is the CPOE measure. We had this one in stage 1 as well. But in stage 1, the measure was for only 30% of meds. In stage 2, that increases that threshold to 60%. And it also adds labs and radiology to the mix, needing 30% of each one of these. Another big change that happened in this additional caveat was added actually back in 2013 that allowed credentialed medical assistants to be able to do CPOE. Prior to that, it was only licensed healthcare professionals, which meant your doctors, DOs, RNs, and LPNs were essentially the only ones who could do CPOE. That program, it has been relaxed to now allow medical assistants as well. The industry took, I'll touch on this briefly because I find a lot of folks don't understand this yet. And really even, I will admit, MCEDA and the entire healthcare industry seem to have misinterpreted what CMS tried to do here. When they changed the rule, they allowed credentialed medical assistants to also do CPOE. The health industry as a whole took the word credentialed and substituted certified in there. And so everyone was under the assumption that the only MAs who could do CPOE were certified medical assistants, your CMAs. That is not the case. That is not true. Credentialed, all that means is that the MA went through an established medical assistant school and graduated from MA school. So in my area here, Ross is one of the schools. There are a few, but I'm just pointing out Ross is a credentialed medical school. There's somebody who's gone through and gotten the authorization to teach medical assistants how to be medical assistants and give them a certification afterward that indicates that they've gone through the schooling. That is enough to do CPOE. They do not have to take it that extra step and also become certified. Certainly certification is better. It's recommended. It's great for the MAs to take their education that step further and become certified, but they don't have to be certified in order to do CPOE. CMS back in October came back and kind of clarified things, issued another, they revised one of their FAQs that kind of spelled this out. But again, they only have to be credentialed, meaning they went through an established, accredited MA school. Once they graduate from that program and can demonstrate to you that they have graduated and can kind of legally use the credentials MA after their name, that's enough to do CPOE. E-prescribing. The stage two increases this threshold from 40% to 50% and adds the additional requirement that this 50% needs to be compared to at least one drug formulary as well. So in stage 1, drug formulary was a menu measure. In stage 2, it is a requirement. You need to have drug formularies turned on, and this is one of those reasons that your e-prescribing needs to be comparing against a drug formulary. Recording demographics. The only change for this measure was in the threshold, increasing from 50% in stage 1 to 80% in stage 2. We'll see this over and over again, where a lot of the measures really just underwent a threshold change for stage 2. So the objectives are really the same. You're just having to raise the bar a little bit and make sure that more of your patients are falling into the numerator for this for the measure. Recording vital signs. The stage 1 measure indicated that 50% of patients have height, weight, and BP recorded. The new stage 2 measure increases this threshold to 80%. As far as the exclusions go, there are exclusions to these as well if you can demonstrate that that some of the vital signs are outside your scope of practice. You can decide to record just blood pressure or just height and weight or vice versa. Recording smoking status. Again, there's only a threshold change in this one. It's the same as stage 1, except for that threshold. In stage 1, we were at 50%. In stage 2, we are now at 80%. The CDS requirements, clinical decision support, these requirements increased significantly in stage 2. So in stage 1, you only needed to implement 1 CDS rule. In stage 2, you need to implement 5 that are related to 4 or more clinical quality measures, as well as ensure that your drug-drug and drug allergy checks are enabled in your EHR. So drug interaction checks was its own core objective in stage 1, but really those drug interaction checks are just CDS rules. And so they kind of, in stage 2, it takes what and kind of combines those interaction checks into the CDS rule requirements. So having the drug-drug and drug allergy checks is still a requirement of the program. They're just kind of buried into the overall CDS rule. So counting the drug interaction checks and the 5 CDS rules, you really have 7 CDS rules that have to be enabled. And these have to be enabled on day 1 of your reporting period. So again, if you did not have all of this in place on January 1st, right now, you're in danger of not being able to attest to meaningful use in 2015. You'll get a reprieve if and when the rules are changed and we go to a quarterly reporting period. That'll get you off the hook, and you can ensure that you've got your 7 CDS rules enabled on day 1 of your quarterly reporting period. So if you're in that boat, you better hope and pray that we do in fact go to a quarterly reporting period. So provide patients the ability to view online, download, and transmit their health information. This is your patient portal. So the first part of this measure is the same as it was in stage 1, which was providing 50% of patients seen during the reporting period with online access to their health information within 4 business days of it being available to the EP. But now you need to show that more than 5% of your patients have used your patient portal to view, download, or transmit their health information to a third party. This can be a difficult one. We have a lot of clients that kind of struggle because you're on the hook for what is the patient's behavior in this instance. So you're trying to drive traffic to your patient portal and get your patients to not only sign up for the patient portal but then actually use it. It's only 5%, but I know that 5% can be difficult to overcome. So the question we get a lot is, how can we force patients to use the patient portal? Marketing is a big part of it. Educating your patients in the use of the tool, demonstrating to them on why it's a great tool, why it really is a win-win for everybody. It's great. It can be great for the patient. It's most definitely great for the providers and your staff as well if the patient portal is being used effectively. Make sure that you have some of the advanced functionality enabled in your patient portal, like prescription refills and the ability to request appointments. Some of those kind of administrative tasks can help drive more traffic to your patient portal, but a lot of it comes down to the way it is being presented to the patients. If it's just being presented to them in kind of a haphazard way that, like, well, we've got the patient portal and feel free to use it if you want, patient. You're not going to be driving traffic there, but if you're marketing it the right way and are demonstrating to the patients on what this patient portal does for them, it's providing them a lot of access to their own health information, and you have some of that advanced functionality enabled, you should find more and more traffic being sent, being redirected to your patient portal. There's a lot of information that is required that really needs to be a part of that patient portal also. It's not just enough to have a patient portal, but if all of the data isn't there within 4 days of it being available to the EP, you haven't met that requirement. So just having the patient portal is not enough. the data actually has to be fed from your EHR to that patient portal. And if it's not, you can't count the patients in that, even in that first part of the measure, in the 50%. For instance, items that must be included, some of the basics, which would certainly be, is patient name, provider's name, office contact information, current and past problem list, procedures, lab results, the current med list and medication history, medication allergy list, the allergy history, vital signs, demographics, smoking status. There's a laundry list of items that have to be populated to your patient portal in order to be able to say that you've met even the first part of that measure, that 50% of the patients are provided online access. It's that it's not just having the patient portal. You have to populate it with a laundry list of information. If you would like to see that list, I would urge you to go to the spec sheet, the one URL that I gave you earlier on. If you go there and pull up the spec sheet, it gives you that laundry list of information, so you can double check and make sure that everything that needs to be on the patient portal is in fact there. Providing clinical summaries for patients for each office visit. For this measure, the threshold has stayed at 50% of patients. However, the time frame has been reduced from providing the summary within 3 days down to 1 business day. So that's really the only change on this one. Before you had 3 days to get the clinical summary into the patient's hands. Now it has to be in 1 day. Protect electronic health information. This is your security risk assessment. There was really no change in this between stage 1 and stage 2. So everyone must conduct or review your previous SRA, and there are no exclusions on this one. So everyone's on the hook. Nothing really changed. You do not have to completely redo your previous SRA each year, but you do have to go back to that old one and review the action plan, demonstrate that you are fixing what was wrong, or those risks that were identified in your previous one, those areas of improvement. You need to demonstrate that you have made significant progress. At the very least, you have to show that you're making significant progress on correcting any of the deficiencies that were identified previously. Just slapping a signature and a date on your stage 1 SRA is not going to pass an audit. Again, you need to demonstrate that not only did you review your SRA, but that you're making significant effort to get it all in the green. Incorporate clinical lab test results into your certified EHR technology. So lab results was a menu objective in stage 1, but is now a core objective in stage 2. Really, if you look at the core requirements in stage 2 and compare and look at the menu objectives in stage 1, all but one of the menu objectives in stage 1 became core objectives in stage 2. The only one that stayed behind is the syndromic surveillance menu measure in stage 1. Stayed a menu measure in stage 2. All the rest of the stage 1 menu measures became core measures in stage 2. So here in this one, lab results, 55% of your lab tests ordered during your reporting period must be recorded in your EHR as structured data. The easiest way to have that happen, I say put easy in quotes because I know that a lab interface is not always easy either, but certainly a live lab interface is the easiest way to get your lab results in as structured data. That is not a requirement. You do not have to have a lab interface in order to meet this objective. It's a painstaking process, but you can actually take that paper lab that you're getting and key those values in as structured data into the patient's chart, into the proper fields, and that is what should be triggering your maintenance use report. It is the lab results in as structured data. It doesn't matter how they get there. Again, certainly lab interface is easiest, but you can just manually input them into the patient's chart, into those structured data fields, and that will count for the measure as well. Generate lists of patients by specific conditions. This measure moved from an optional menu item in stage 1 again to a core objective in stage 2. You get to decide what condition is clinically relevant or useful to you and then generate a report from your EHR of patients with that condition. This is really, honestly, in my opinion, one of the easiest measures to meet. There are no exclusions for it. Everyone is on the hook for it, but I know nearly everybody chose this as one of their menu measures in stage 1 because it is not a difficult one to do. You just pick a disease state or a diagnosis or whatever in ICD-10 code in your EHR. So it's something that's clinically relevant to the EP, generate a list that shows the EP, what patients they have and, that fall in that category. Make sure you keep a copy of that in your audit file and you've met this measure. Identify patients who should receive reminders for preventative or follow-up care. This is another measure that moved from menu in stage 1 to core in stage 2. This measure has also undergone a significant overhaul. In the stage 1 measure, more than 20% of all patients 65 years or older or 5 years old and younger were sent an appropriate reminder during the EHR reporting period. Now in stage 2, we're targeting patients who have more frequent contact with you. So over 10% of patients with 2 or more office visits within the last 24 months need to be sent a reminder. This reminder should be sent by whatever the patient's preference is of the communication methods available. It could be by snail mail, individual phone call, automated system reminders, or perhaps some other form of secure electronic communication like through your patient portal. Another way to drive traffic to your patient portal is use it to communicate reminders. So in the typical workflow, the patient would get a notification that you have sent them a reminder, and to access it, they have to access their patient portal. When they access that reminder that you've sent them, it's going to trigger your that 5% of patients that actually have to be using your patient portal. So if you strategically use some of the requirements for these other measures, it can help drive numerators in other measures, especially the patient portal. This is not the only way to get patients to drive traffic to your patient portal, but it definitely is one of the ways. Also, there's a lot of discussion or confusion about what this means, like what is a reminder for preventative or follow-up care. So just reminding your patients that they have an upcoming appointment, that doesn't count. It is to remind them to, one of the ways is to remind them to schedule a future appointment. So if they're due for their annual exam, you reach out to them and say, hey, it's time for you to call us up and schedule your annual exam. That's the kind of reminder, but it's a lot more broad than that. You can actually remind them to take part in really just about any kind of preventative care, and that's going to count for this reminder. You could be reminding them to follow their post-op instructions. You can remind them to get a flu shot. You can remind them to get their labs done. There's a lot of opportunity here. You're not relegated to just reminding them to schedule a future appointment. You could run a list and find out who all your smokers are, and you could reach out to them and remind them that they need to quit. And here's the information on the local hospital or health system's smoking cessation program, and that would count. So it's just reminding them to receive preventative or follow-up care. So it's that preventative part. So think broadly about what it is you can or should be reminding your patients to do, and it can be used for this measure. Identify patient-specific education resources and provide those resources to the patient. So the only change to this measure in stage 2 was to change from menu objective that you could choose to do to a core objective that you now must do. So the ability to recommend educational resources to your patients with the help of your EHR is one of the certification requirements for your 2014 cert. Basically, as you are entering information on the patient during the patient visit, you're registering that they smoke or whatever it is. There's a thousand things that will trigger education materials So your EHR is noticing the radio buttons and all the structured data that you're inputting, what their diagnosis is, and it is then taking that information and it's looking at an internal education database, and somewhere in your EHR, it's not always easy to find, it is going to be recommending education materials based off of information you have entered on that patient. You print out those education materials, and it's going to trigger a meaningful use report. You do not have to use the information that is hard-coded into your EHR. If you have a smoking cessation pamphlet that you've been using since 1977 and you really, really like it and want to continue to use it, you can use that instead of what the EHR is suggesting. Hopefully your EHR, not all the vendors have this functionality built in, but there hopefully will be a checkbox there just to indicate that you can check it off to say that you've given the patient the education materials. The important part is that you are giving them the materials that the EHR is suggesting. It's kind of the heart of the measure. It is using structured data to suggest appropriate education materials and delivering those education materials to the patient. Perform medication reconciliation. Again, on this one as well, the only change was to move it from an optional menu objective to a mandatory core objective. More than 50% of patients transitioned into your care, you must perform a medication reconciliation, comparing the med list that you received from the patient, hospital, or other provider against the information in your own EHR. Provide summary of care record for each transition or care or referral. This is a big one. This one, yeah, this is a big one. This is a sticky one. So again, this measure moved from a menu in stage 1 to core in stage 2. The requirements are now also significantly expanded for this measure. So under stage 1, only measure 1 was included, which indicates you must provide a summary of care record for more than 50% of transitions of care. And the method by which you provide that summary of care to the next provider of care did not matter. It does not matter in stage 1. It still doesn't matter in stage 2. You can get it to them by any way, shape, or form. It can be by fax, by mail. The patient can actually deliver it if there's a reasonable expectation the patient is actually going to deliver it to the next provider of care. Smoke signal, pigeon, however you want to get it to them. It's measure 2 and 3 that are added in stage 2 that provide quite a big headache. This is a difficult measure to overcome. So in measure 2 under this one, 10% of these transmittals of the summary of care document must be electronically transmitted via your EHR. This can be either through the direct transport technology that should be embedded into your EHR, or through an eHealth exchange participant. So one of the HIEs, or there's a few options there. And each vendor is a little different on what's available. But 10% of these documents have to be sent electronically to that next provider of care. And then additionally, in the third part of this measure, either one or more of these exchanges must be with a recipient who has a different EHR system than you. Or you must conduct one or more successful tests with the CMS-designated test EHR during your reporting period. That's something called the CMS randomizer. If you just Google CMS randomizer, it'll come up with the page that you need to go to. So you only need to use that if just in the regular course of transmitting 10% of these documents, at least one of them isn't going to somebody who has a different EHR than you. So again, yeah, this one is pretty tough to overcome, and this one also had some additional caveats last year as far as flexing for folks that could not connect with enough providers to send this. We're actually able to flex back down in 2014 as well. So kind of in summary on this one, for over half of the patients, you refer to another provider or transfer to another setting of care. You have to send the next provider of care in any way, shape, or form the summary of care document that's generated right from your EHR. Of those documents, you need to send 10% of them electronically, either directly to the recipient or using the eHealth Exchange standards. And then at least one of those summaries of care documents that are sent electronically must be sent to someone who has a completely different EHR than you. Or, if that's not an option, you can use the CMS randomizer as well. Lots of hoops to jump through on this measure, and is, I would dare say, the most difficult measure to attain in Stage 2. Submitting electronic data to immunization registries. As part of the new 2014 certification criteria, your EHR will come equipped with the ability to electronically send immunization data to MICR. So in Stage 1, you had the option to test your EHR's ability to electronically transmit this information to MICR. Now in Stage 2, you're on the hook for successful transmission of this data on a continuing basis, unless you're excluded for any of the reasons listed above, which really the only exclusion that fits in the state of Michigan on this is if you do not administer any immunizations. The exclusions you're reading here on this slide that talk about if you operate in a jurisdiction, you do not operate in a jurisdiction that falls into these. So the only time you can exclude from this measure is if you just do not administer any immunizations. So on the touch, there's a slide later in just a little bit that gets into what it means to meet this measure. There's some kind of interesting scenarios that that you don't necessarily have to be in ongoing production in Stage 2 in order to attest yes to this measure. There's 4 scenarios that I'll get to on a future slide as well in just a minute that kind of explains how you can still meet this measure without necessarily being in full production mode. Using secure electronic messaging to communicate with patients. This relates back to the portal in most instances here, but to meet this measure, more than 5% of unique patients must reach out to you via the electronic messaging function of your search. So not only, so it kind of comes back to that patient portal. It's kind of an additional measure that relates back to that. So not only do you have to get folks signed up to your patient portal and be pushing the appropriate data to the patient portal, you have to get a certain percentage of your patients to log into your portal. You also need to somehow get your patients to communicate with you through that patient portal as well. It can be to either the EP or their clinical staff. One great thing to keep in mind here is that the message does not have to be initiated by the patient. So one way to start to drive traffic and get folks into the numerator on this message is to have your clinical staff, your provider, reach out to patients via the patient portal. Have them initiate the message. You can't send out a blanket message to all the patients. It does need to be clinically relevant and kind of a one-on-one communication. But your clinical staff, for instance, there's just one example. Look at who had problem visits or office visits last week and that you provided care to. Reach out to those patients and say, hey, you were in the office last week for this problem. How you doing? We just want to check in and see if the issue is resolved. Is there anything else we can help you with? You need to reschedule another appointment. When they reply to that message, it counts in this measure. So you do not have to, it does not have to be patient initiated for it to count. I know some of the vendors, there are issues where the vendors are possibly not counting those, and the vendors have it coded that it has to be patient initiated, but that is not part of the measure. It does not matter who initiates the message as long as the patient sends a clinically relevant message to the provider or their clinical staff. Another thing that can trigger this measure, another reason to have that advanced functionality enabled in your patient portal, is medication refills count for this measure. So if you are offering the ability to request medication refills through your patient portal, every time that happens, that counts as a secure message from the patient to the provider or the clinical staff. So those should be triggering the 5% of unique patients that's needed here as well. Okay, so we've gone through the core measures. We're going to move on to the 6 menu measures here. So one of the things that changed a little while ago. You could, in previous versions of Meaningful Use, be a meaningful excluder, meaning if you qualified for an exclusion for one of the measures, you could count that as one of the measures that you met. That is no longer the case. You cannot be a meaningful excluder. You have to be a meaningful user. So while some of the menu measures offer exclusions, these exclusions no longer count as having met one of the measures. So if you do qualify for the exclusion, you need to examine the other measures available and find 3 that you do. If there are 3 that you do not qualify for the exclusion on, you have to pick those 3 and report on them. If it turns out that you are excluded from 4 out of the 6, in that instance, you would report on the other 2 and claim an exclusion for you'd have to enter the exclusion on all 4 of the other ones, and then that would actually count as having met the requirements for the program. But so an exclusion only counts as having met a measure if you exclude from at least 4 measures. Submitting electronic syndromic surveillance data to public health agencies. So this is the MSSS in Michigan here, the syndromic surveillance system. So similar to the MICR measure, in stage 1, the objective was simply to test your EHR's ability to electronically transmit the syndromic surveillance data. In stage 2, this measure expands, again, to try and get you to be in ongoing production in the syndromic surveillance system. As far as the exclusions go, this one, we get there's a lot of confusion out there on this one on whether, folks are finding out now, especially as they get audited, that they thought they could be excluded from the syndromic surveillance, but are finding out that they really don't. Very rarely does somebody qualify for the exclusion on the syndromic surveillance measure. There are only 6 provider types who are excluded: podiatrists, dentists, optometrists, ophthalmologists, certified nurse midwives, and chiropractors. If you are not one of those provider types, you do not qualify for the syndromic surveillance exclusion in Michigan, period. We do not operate in a jurisdiction that doesn't have syndromic surveillance alive and well. Michigan was actually kind of the first state in the country that brought their syndromic surveillance system online and is pushing it down to the individual provider offices as well. So again, the only time you could claim an exclusion from this measure, this is in stage 1 as well, is if you are one of those 6 provider types: podiatrists, dentists, optometrists, ophthalmologists, certified nurse midwives, and chiropractors. Record electronic notes in patient records. This is a new one, new measure for stage 2, but it's fairly straightforward. If you select this menu measure, you will need to enter progress notes into your EHR for over 30% of unique patients with at least 1 office visit during the reporting period. Note that these progress reports must be created, edited, and signed by the EP. If you're using a scribe, you just need to make sure that the EP is reviewing and signing off on what the scribe is entering. If that does not happen, it doesn't count for this measure. So it is okay to use scribes. You just need to make sure that the EPs are reviewing and signing off on those notes. Another new addition for stage 2 is the imaging results accessible through your certified EHR technology. For over 10% of all tests that yield an image, the test results must be accessible through the EHR. This means either stored directly in the EHR or through a direct link in the EHR to another system like PACS. So this is not, this one can be tough. Just need to make sure that the image itself is accessible right in the patient chart. So you can't leave your EHR and access your PACS system unless there's a direct link right in your EHR that with one click it'll bring up that image. If you're logging out of the EHR and logging into PACS and then searching for the patient and bringing it up, that's not going to count. There needs to be that the image either has to be embedded directly into the patient's chart, or with kind of one click you can leave the system and go to PACS, but it has to bring up that patient's image right there. Recording patient's family health history. For this optional measure, you must record family health history for over 20% of your patients, and this history must include one or more first-degree relatives. You can only claim exclusion on this measure if you have no office visits during your reporting period. So it's fairly straightforward. Report cancer cases to a public health central cancer registry. So as part of the 2014 EHR certification, your EHR has the ability to electronically transmit cancer case info to a public health center cancer registry, so to MDCH's cancer registry. For this measure, you must successfully submit this info electronically for the entire reporting period. Again, there are 4 possible exclusions for this measure, but only the first one applies in Michigan. Again, we are progressive enough here in Michigan that you do not operate in a jurisdiction where this does not apply. And finally, the menu objective of reporting specific cancer cases to a specialized registry. This objective is very similar to the previous one involving cancer, only in this measure you're choosing another disease state relevant to your practice and submitting data to a specialized registry associated with that specific disease. Likewise, the exclusions for this measure are similar to the previous measure, and right now the only other specialized registry offered by the state of Michigan is their birth defects registry. Okay, so I alluded to there being some interesting scenarios or ways that you can still attest to yes for the public health measure in stage 2. So for MICR, or primarily I'm talking about MICR or syndromic surveillance. In stage 2, if you read the spec sheet, it indicates that you have to be in ongoing production in order to attest yes. Either one of these 4 scenarios, if you meet the requirements for one of these 4 scenarios, it allows you to attest yes to the measure. So in scenario 1, that's kind of the way the spec sheet on the measure spells out that you're actually in ongoing production. But there's the other 3 scenarios that allow you to not be in ongoing production in syndromic surveillance or MICR, but still attest yes. So if you've registered intent within 60 days of the EP's reporting period and then you achieve the ongoing submission. You can also, as long as you're actively engaged in the onboarding process, so you're engaged with either MICR or syndromic surveillance, and you're doing everything you can to, you're submitting regular test messages to kind of refine that message to get the green light that your message is good. If you're engaged in that process of back and forth, and you're taking that feedback, making that change, submitting another test message, even if you do not, even if by the end of your reporting period you haven't gotten that successful green light on your test message, it's still going to allow you to attest yes, because the important thing here is that you are working towards ongoing production. As long as you are actively engaged with the state of Michigan and are doing what you can to get onboarded and get into production, you should be able to attest yes to meeting either the MICR or the syndromic surveillance measures. Registering intent within 60 days is a requirement in the program. It's kind of, in my opinion, a sort of a weird one. But within 60 days of the start of your reporting period, you have to communicate with the state of Michigan and register your intent to pursue ongoing submission. Depending on what you did in stage 1, if you did anything, what that means could be a little bit different. So if you didn't complete any testing in stage 1, so as you enter into stage 2, this is the first time that you are taking part in one of the public health measures. If you follow the steps in this tip sheet, which is the kind of the base registration piece where you're filling out paperwork and starting that onboarding process with the state of Michigan, that will actually double count, and it automatically registers your intent. If you completed public health testing in stage 1, you need to send an email notification within 60 days of the start of your reporting period There's a different email address on your screen right now, one for MICR and one for syndromic surveillance, on how to do that. So you send them a message with the NPI, the provider's name, and with a message that says, I'm in stage 2 this year, and I'm registering my intent for ongoing submission. Just send that off to either one of these email addresses, and you'll get a response back within a couple of weeks that confirms your registration of intent. Make sure that you keep that message, print that out, print out that proof of having met the registration of intent requirement, and put that into your meaningful use audit file. So in the event that you get audited, you'll be able to easily demonstrate to the auditor that you did, in fact, register your intent within 60 days. The cancer registry and specialized, the birth defect registry or specialized registry, these are new in stage 2, so no one did any onboarding in stage 1 for either of these. So if you follow the information in the tip sheet on the prior slide, will kind of double count. It'll count as your registration of intent when you begin the onboarding process as well. The state of Michigan has a great informative website for their public health reporting. It's actually, out of all the meaningful use pages and whatnot on the state of Michigan, this one gets the most hits, is the public health. So if you have any questions, concerns, comments, more information, it's actually a very comprehensive site. There's great guides and how-tos and whatnot. They did a good job of kind of spelling out what the onboarding process is like for public health. So I urge you to go to the URL on your screen right now and can get a wealth of information. Clinical quality measures, there was no difference really between last year and this year on your clinical quality measures. If you're in stage 2, you should understand exactly what's happening with these clinical quality measures. There's no thresholds that have to be met. You just simply reporting the data that as it comes right out of your certified EHR technology. In 2014, the reporting changed a little bit. Whether you're in stage 1 or stage 2, with the state of Michigan, I think we're still trying to figure this one out. But on the federal side, the Medicare providers, anyone who is beyond their first year, so anyone in their second year and beyond of meaningful use, must electronically report their CQM data. MDCH, the Medicaid folks also have the ability to upload a QRDA file of their CQMs, and they're encouraging anyone, they would like everyone to follow suit, that really anyone beyond their first year of meaningful use should be communicating their CQMs or uploading their CQMs electronically, either through if you're in the Medicare, you're using the federal system, and the Medicaid, you're using CHAMPS. If you're in the Medicare program, you also have the ability to report once with your CQMs and have it get dual credit for the meaningful use program as well as PQRS. Although with PQRS, it is a year-long reporting, so it is not quarterly reporting for PQRS. So if you go this route, it means you are actually submitting an entire year's worth of CQMs only to the federal site, and that will take part. That will give you credit for both the meaningful use program as well as the PQRS program. That option is not available if you are in the Medicaid EHR incentive program. Prior to 2014, the old version of meaningful use, you were reporting on 6 out of 44 CQMs. You are now reporting on 9 out of 64 CQMs, and those CQMs must cover at least 3 of the 6 NQS domains. And there's a set of adult and pediatric recommended ones, but again, they're just recommended; they're not mandatory. As long as you can pick 9 CQMs that cover 3 out of the 6 NQS domains, you're good to go. These are the 6 NQS domains. Each of the 64 will fall into one of these, and to be certified, your vendor will be offering at least enough CQMs to be able to meet this requirement. So they're offering at least 9 that covers these 6 domains. hopefully your vendor is offering a lot more and getting and hopefully adding more all the time to give you more options and more flexibility in the CQMs that you are reporting. Some of the bigger ones like NextGen and whatnot are offering all 64 of them now, but some of the other vendors are not yet. Yeah, this just gives you kind of a snapshot of out of the 64, there's that covers should cover everybody. You should be able to find enough CQMs that are relevant to your scope of practice to give you 9 out of the 64. So what do you need to have on day 1 of your reporting period? I alluded to this a little bit earlier. So some key items to have set on day 1 of your reporting period. You must be on your 2014 EHR technology. So again, if we are stuck with a year-long reporting period and you are not upgraded to your 2014 technology on January 1st, you will not be able to attest to meaningful use. Because that is the day 1 of your reporting period, and you must be on 2014 technology. If you're still upgrading, you've got to hold up hope that CMS is going to do what it appears they're going to do and switch to a quarterly reporting period. But regardless of whether it's January 1st or quarterly, you need to be on 2014 cert. You need to have all your CDS rules enabled. So that's 7 different CDS rules that have to be enabled on day 1 of your reporting period. All your yes-no measures have to be enabled. So anything that doesn't have a threshold, but you're just attesting to yes or no, you need to have that functionality enabled in your EHR on day 1. You need to identify your menu measures and make sure you know what those targets are and know what you're shooting for to ensure that you're changing workflows or doing everything that you have to do to make sure that you hit those menu measures. You don't want to wait until the end of your reporting period and then go, well, let's look at the 6 and see which 3 we met. Identify those 3 that you're going to be shooting for before you even start your reporting period so that you know exactly what you're working towards. Not a requirement to have a lab interface, but it will certainly help you tremendously if you have your lab interface up and running on day 1 of your reporting period. And if you're still lagging behind and still looking for upgrades, make sure that you are pressuring your vendor and communicating with them constantly on the timeliness of those upgrades. You want to make sure that, again, the biggest one being if you're still stuck on your 2011 technology, you need to get that upgraded ASAP. Not being prepared with these things will stop you from being able to test, or could stop you from being able to test in 2015. Okay. That leads us up to questions. We have about 10 minutes or so to answer any questions. We've had quite a few of them come in. Get to those here. Can answer as many questions. If you have a question for me, please type it into the question box in your GoToWebinar interface if you have not already. And I will answer as many of these as I can. The system also keeps a log of all these for me, so if by some chance I am not able to answer all the questions in the next 10 minutes, go ahead and fire the question off to me anyway, and I will send you an email afterward and make sure that you get the answer to your question. It looks like Leslie has been helping and answering some of these for me as well. One question was, is the slide presentation, is it available after the webinar? It's actually available right now. If you go to the mcga.org website, there is a resources tab, and then under resources, there's a webinars tab. If you go to webinars, you will see the PDF, the slide deck for today, as well as all of our previous webinars as well. Let's see. For stage 3, do you expect that the menu items will become core items? Yes. For the most part, I would kind of expect a lot of what we saw going from transitioning from stage 1 to stage 2, where the cores or the menus became cores for stage 2. We'll probably likely see a very similar thing happen with stage 3 as well, where items that were menu in stage 2 will become core in stage 3. But I'm kind of holding my breath and waiting for some official word on what the stage 3 measures are going to be. And we hopefully, as there's some debate on when we can expect the stage 3 stuff to come out, but it could come out as early as this month. So it would be great to see that. Would you consider sending a patient to diabetes education, a transition of care? So it depends on kind of who is conducting that diabetes education. It is another provider of care. So if you're transitioning to another provider of care, that would count as a transition of care. I think when in doubt, you can count them, but it depends. Is it a licensed clinical person that you're sending them to? Then the answer is yes. That is that you're transitioning them to another provider of care. If you're sending them to physical therapy, that's going to count. Those are providers of care. So because it kind of depends on that education. I wouldn't. It's not necessarily if they're just attending a diabetes class. That's like a group class. That's not going to count as a transition of care. So kind of the trigger is are they seeing another provider of care on that other end? Those will count as a transition of care. But specifically, it is to another provider of care. For the public health reporting, can you explain if we need to do a test every quarter to qualify? We are hearing that we need to do a test every quarter, and if we attest the last quarter, we would have to do those tests in each quarter. There's some ongoing debate on this one. I agree with you. The state of Michigan would like to see, going by those guidelines and what they want to see, they encourage one test message every quarter. Honestly, I do as well. I recommend it. It's part of demonstrating the commitment towards achieving ongoing submission. So I would suggest doing at least one test message every quarter if you can. Really, to meet meaningful use, though, if we stay in a year-long reporting period, that is in fact true. You should be doing one test message a quarter. If it shrinks down to a quarterly reporting period, technically, to meet the meaningful use requirements, one test message during your reporting period is going to do it. But again, that's only in effect if we do in fact go to a quarterly reporting period. So there is some debate on this one. If you can do a test message every quarter, I would suggest it, regardless of whether we stay in a year-long or quarterly reporting period. Get those test messages refined, do the work to get that green light to the point where your test message is good to go, and you don't got to worry about it. You're done. You're in that regard. So just keep refining those test messages. But technically, to meet the meaningful use requirement in a quarterly reporting period, a single test message will suffice. How can CMHs do the public health measure when we never give immunizations? So there is not a requirement there's not a requirement for public health in stage 2. You in stage 1, there were the 2 public health menu measures, and you had to choose one or the other. You don't in stage 2. There is not a public health requirement per se, although technically the MICR measure moved over to core, which somewhat makes it mandatory. But in that instance, if you don't give any immunizations, you're going to claim the exclusion on that, and you're all set on that measure. But there is not a requirement like there was in stage 1. So in your case, if your CMHs don't give immunizations, and you're not giving immunizations anywhere else, you're going to meet what is essentially a public health requirement in stage 2, because you qualify for the exclusion on the MICR measure. But in that instance, you are not forced to then do the syndrome and surveillance measure. That is a menu measure, and you're not required to participate in that one. certainly encourage it, especially if you did start the onboarding process in stage 1. I would recommend that you stay on that path and you know, continue with that very important work of getting onboarded in the syndromic surveillance system. Our CMH is still in stage 1, and we're told we cannot claim exemption for public health measure. You can actually, if you are excluded from both public health measures in stage 1, so you don't give any immunizations, and you're one of the 6 provider types in that can exclude from syndromic surveillance, you can claim exclusions on both of your public health measures, and that is an instance where claiming exclusions actually does count as meeting a measure. So if you're able to claim exclusions on both MICR and syndromic surveillance, that counts as having met one of your menu measures, and so then you're only attesting to the others then. Follow-up comment is we are not one of the 6. We are mental health. So you are on the hook for syndromic surveillance. So you don't give immunization, so don't worry about that one. But you are most definitely on the hook for syndromic surveillance in mental health. So, yeah, you're not one of those 6 provider types. So in stage 1 for mental health, you must do syndromic surveillance. In stage 1. In stage 2, you do not. Although, as I said, if you started the onboarding process, I highly recommend you stay on track with that. That is, I don't see any other questions in. We've got another minute or so for if there's any last-second questions that come in. My email is also up on the screen right now. If after the presentation you think of a question or if there's anything I can help you with, please don't hesitate to either call or shoot me an email, and I would be happy to answer that offline. With that, I'm going to turn things back over to Leslie to wrap us up.
Yes, thank you again for your patience and sticking with us through our technical difficulties. We're going to be having a webinar again in April. I believe it's April the 8th. The topic is to be determined. We are working on a PQRS presentation, and that will be either in April or May. And we also have a security risk analysis presentation coming up as well. So check your email. I'll be emailing those dates out as soon as we have them. We appreciate your time. Have a great afternoon.